Hello, my name is Jami Young, and I am a third professional year Doctor of Pharmacy candidate, and I am here to talk about my journal club, which was done on the article Clindamycin versus Trimethoprim sulfamethoxole, also known as Bactrim, for uncomplicated skin infections. This article, it comes from the New England Journal of Medicine, and it was published earlier this year in March. The funding for this article was done by the National Institute of Allergy and Infectious Diseases and the National Center for Advancing Translational Sciences. A little background on this article, or I guess the reasoning that they decided to do a study on I guess in the comparison of clindamycin versus Bactrim for uncomplicated skin infections is because in the United States, the presence of patient or the percentage of patients that are presenting to emergency departments that have skin soft tissue infections that are caused by community acquired MRSA is increasing over the years. And right now, clindamycin and Bactrim are the two drugs that are most commonly used to treat these infections. And the article is entitled Clindamycin versus Trimethoprim sulfamethoxole for uncomplicated skin infections, but in the article they solely focus on abscesses as well as cellulitis. So those were the only two skin soft infections that they were looking at when doing the comparison of these two particular drugs. Currently, clindamycin is FDA approved for the treatment of staphylococcal infections, and it is listed in the IDSA treatment guidelines as a current treatment. However, Bactrim is also listed in the IDSA guidelines as a treatment as well, but Bactrim is not FDA approved for the treatment of staphylococcal infections. And so in this study, they decided to compare the efficacy of the two and see which drug is more superior to the other, because right now there is no particular treatment. Either or agent can be used, and no agent is better than the other agent. So I guess the overall objective of this particular study was to provide an 80% probability that one drug would be more efficacious or absolutely superior in treatment of these uncomplicated skin soft tissue infections than the other by at least a 10% margin. And the uncomplicated skin soft tissue infections that they used in this particular trial were defined as large area cellulitis or large area abscess. Um, the trial design for this, it was a multi-center prospective randomized double-blind clinical trial, and it took place in 4 locations throughout the U.S. One location was in Chicago, Illinois. There were 2 locations in California, one in San Francisco and the other one in Torrance, and then the final location was in Nashville, Tennessee. They took place in the outpatient facility, so all of these were uncomplicated. All of these patients were treated in the outpatient setting, and in order for to be included in this study, they started with that patients had to present with 2 or more of the following skin characteristics for at least a period of 24 hours, and that included redness, swelling or induration, warmth at the site of infection, purulent fluid drainage, and tenderness to pain or palpitation. And so in order to qualify for initial qualifications, a patient had to have at least 2 of those things for at least a period of 24 hours. And then the patients were divided into 2 subsets, and they were determined to either have cellulitis or abscess. And then there was an additional subset of patients who had both cellulitis and abscess. And in this particular study, cellulitis was defined as inflammation of the skin or skin structures and without the presence of any fluid drainage. And the abscesses were defined as a an area that had the appearance of a collection of pus or fluid. And of course, those individuals who had both inflammation of the skin as well as a collection of fluid. And then the patients, they underwent a evaluation to determine if their skin soft tissue infection was a large abscess or cellulitis or a small abscess or cellulitis. And large was determined as a patient who was 8 years or older, having 5 centimeters or greater diameter. For their skin soft tissue infection, for those patients who were 1 years of age to 7 years of age, 4 centimeters in diameter, and then for those patients who were 6 months to 11 months, their skin soft tissue infection had to be 3 centimeters or greater to be determined to be large. For those who had small skin soft tissue infections or abscess, they were not included in this particular segment of the trial. This only focused on your large abscesses and cellulitis. And your exclusion criteria for this particular study were those patients who had superficial skin infections, infections in particular parts of the body that required special management. You couldn't use your typical treatment options for those places. If a patient had a human or a animal bite, for those patients who were 6 to 11 months and they had a fever that was greater than 38 degrees Celsius, or for those particular patients who were older than 11 months and their fever was greater than 38.5 degrees Celsius. Immunocompromised patients were also excluded from this trial. Morbidly obese patients were excluded from this trial. Any patients who had recently received any antimicrobial therapy within the last 14 days were excluded from this trial. Anyone living in long care living facilities, anyone who had had any type of cancer treatment within the past 12 months or any major surgeries within the last 12 months were also excluded from being eligible to participate in this particular trial. But for those who were able to participate, it was anyone who had a uncomplicated or who had cellulitis or an abscess who displayed two characteristics of skin soft infections within 24 hours, and they range from the ages of 6 months to 85 years of age. The primary endpoint of this trial was to compare the cure rate of clindamycin and Bactrim for the treatment of patients with cellulitis or large abscesses at the test of cure visit, and the secondary endpoint was to estimate the cure rate between clindamycin and Bactrim and their differences, and then also to compare the adverse effects that would be treatment limiting. At the end of treatment visit, it was the comparison at the 1 month visit or the 1 month follow-up, and then also comparing the two agents in children as well as in adults. After this study took place, there was a test of cure treatment that took place anywhere from 2 to 7 days at 2 to 7 days after the conclusion of the trial, and then 1 month after that test of cure visit was the 1 month follow-up visit. The duration of this particular study, it took place from September of 2008 through July of 2011. And the population in which this trial took place in, it was a fairly diverse population. It ranged, as I said before, the ages was anywhere from 6 months to 85 years of age, with the mean group being 27.1 years of age. 155 of the 524 participants in this trial, which equated to about 30% of it, were pediatric patients less than 17 years of age. As far as your race demographics, you had 53.2% of the participants were African American, 40.3% of the participants identified themselves as white, and then 28.6% of the participants identified themselves as Hispanics. And as far as your male to female ratio, 52.3% of the participants were males. So the study was fairly diverse in age, race, and gender. The arms of this particular study. So there were two groups for the study. There was clindamycin, and then there was Bactrim. For those particular patients who were taking Bactrim, they also received one placebo dose. The study in itself, it started out with 851 patients who were assessed to see if they were eligible to participate in the trial, and of that, 841 of those patients were eligible. When they were divided into large versus small abscess and cellulitis, 554 of those patients were classified to have large area cellulitis or abscess, and they were placed into the intent to treat group. From that 524, 264 of those patients were placed in the clindamycin group, and 260 were placed in the Bactrim group. All the patients with abscesses, they did receive incision and drainage of the abscess before undergoing the antimicrobial treatment, and cultures were obtained. The clindamycin group, they received two 150 milligram tablets that were dosed 3 times a day. And then your Bactrim group, they were dosed two single strength doses, which were given 2 times a day. And then there was one daily placebo dose that was given. And then this treatment, they was given anywhere from 7 to 10 days. For the treatment, and then the test of cure took place after that, and then a follow-up evaluation was done 1 month after the completion of therapy. For that, we found that the study with 160 of those patients were determined to have abscess, and then 280 of the patients had cellulitis. 82 had mixed infections, and there were 2 that did not have a definitive did not have a definitive diagnosis as to whether what type of skin soft infection that they had. And at the conclusion of the trial, 466 of the 522 participants were evaluated at the test of cure. During the test of cure window, and from those, it came back that 80.3% of the clindamycin group were determined to be treated, and 77.7% of the Bactrim group were cured from their skin soft tissue infections, and the p-value between those two was 0.52. So that shows that there was no significant value or no significant difference between the two. And then when we look at the secondary endpoints at the 1 month follow-up, it showed that 73.1% were cured with the clindamycin, and 67.7% were cured with the Bactrim. The numbers did decrease a little bit, but the p-value yielded 0.18, which is still no significant difference between the two. And the common adverse effects that were seen between both agents were diarrhea, which was the most. It was 9.7 for clindamycin, 10.1 for Bactrim. Nausea, 2.3 for clindamycin, 2.7 for Bactrim. Vomiting, 2.3 for clindamycin, 1.6 for Bactrim. Pruritus, 1.5 for clindamycin, 1.2 for Bactrim. And rash, 1.2 for clindamycin, 0.8 for Bactrim. So with those, there were no significant differences between the side effects either. So the side effect profile were about the same. And so at the conclusion of this study, it was found that there was no difference between clindamycin and Bactrim with respect to either efficacy or side effect profile, or the treatment in cellulitis and abscesses. Some of the major strengths of this trial was that it was a multi-center prospective randomized double-blind clinical trial. So it did allow facilities in different parts of the country, and that took away any bias that may have occurred as a result of resistance in a particular place. The randomized double-blinded was a strength, and it took away bias that may have occurred between the patient or the or the practitioner. But the weakness is in the 1 month post-treatment, it did not take into effect that the patient may have been reaffected, and not necessarily that it was a failure in therapy. And then there was no also, not every patient or incision and drainage is recommended as one of the treatments by the IDSA guidelines. So that was not taken into consideration. So incision and drainage could have been a cure for some of these infections, and not necessarily the antimicrobial. So with this, I don't believe that this study had a great impact on the way that community acquired MRSA is treated, but it can be used as a confirmatory resource that there is no difference in the medication that is currently being used. I mean, so thus the providers, they have their choice of drug treatment, which can be based off of preference, susceptibility, of resistance patterns in the area, or patient allergy. But there is no difference between clindamycin and Bactrim in the treatment of large area cellulitis and abscesses. Thank you.